What we're going to do this afternoon is focused purely on billing. And what we're going to talk about is we're going to talk about billing, we're going to talk about denials, we're going to talk about commercial payers, Medicare managed care, Medicaid managed care, and we're going to talk about self-pay. For any of you who don't know me, hi there, I'm Maggie Adams, and I'm with EMS Financial Services. And the fine state of Louisiana and the Louisiana Rural Ambulance Alliance invited me to join you and bring you education on documentation and billing, and I'm thrilled to be here. I only hang with cool kids, and I've met a few cool kids since I've been here. I have been to Louisiana before, so I already knew you had cool kids here. I always start with a disclaimer, and the disclaimer is, yes, our material is copyrighted. Please don't use it without asking us first, because there are federal laws that protect that. As I told you, EMS Financial Services is my company. Some of you may know me. If you are certified ambulance coders and you went through the online program, you've heard me, because I worked with Page Wolf Perkin Work for years. And we started the ABC3 conference, and we started the Certified Ambulance Coder program, and my voice is still on their system, so you may recognize me from there. I was the non-lawyer in the group. EMS Financial is my company. I have a wonderful staff because I only hang with cool kids. And we audit people, so we take claims, and we audit documentation, and we come and do billing assessments, and we do a lot of education. And I write a lot. I write in blogs. So visit our website. I have 2 4-letter words that I'm very proud of: free and sale. So there's free information in the blogs on ICD-10. There is one blog article that you could look at, and it is about getting ready for ICD-10. I actually wrote it last year, and it has a link in it to an article written by Marie Johnson, who is a gal in Texas. Marie runs a billing company in Texas. And Marie talks about things that you can do to get ready for ICD-10. And she wrote that article for Zoll, because she uses Zoll software. If you are worried about ICD-10, check your software company. Zoll, TriTech, AIM, MetaPoint, did I miss any? ESO. There's a bunch of software that you all use. The software companies have been working on this, and they have resources available. Even if you don't use Zoll, they have a pretty robust system that you should be able to check some of their articles or sign up for their alerts. They're going to want to sell you software, and they will send you notes about software, but realize that some of the resources are valuable. So those are some places that you can go to find some information about ICD-10. And I've given this to all of you. I remind you again, my cards are here. If something comes up and you have a question after this, and it will, we're throwing a lot of information at you, and you may wonder about it later, or something will come up. Don't hesitate to reach out. My email is there. My phone number is there. You are welcome to have access. Breaking news. Scientists have discovered that ambulances and taxis are in fact not the same thing. Has anybody mentioned that to patients? Better yet, has anybody told the facilities? Because what do the facilities want? Patients moved. Your problem is not their problem. Their crisis is not your emergency, but they think that it is. So, we talked about some of this morning, and I told you we would touch on the same things. We're going to look at it at a slightly different perspective. Why do you have to document and bill properly for ambulance? Because it is the law. Medicaid and Medicare are not insurance plans. They're the law. And that's why we have to do things. And when you communicate with the crews, you're not asking them to get insurance information. You're asking them to follow the law. A law that's been around for 50 years. It's President Johnson signed the Social Security Act 50 years ago on July 30th. And on that date, we learned that ambulance transport will be covered and reimbursed if the patient can't go any other way for their health. In other words, was medical necessity met? And medical necessity is what we're looking at when we're looking at documentation. And it all overlaps. And that's what happens when you're reading a trip report. When you're in billing and you're reading a trip report, you're looking at these three things that overlap each other, because you need to know how an ambulance was dispatched. Because if you know how an ambulance was dispatched and it's properly documented that it was an emergency response and it was dispatched ALS, and you know your dispatch protocols, this call might just qualify at the ALS 1 level of reimbursement. How can you in billing learn that information? You need access to the dispatch protocols. Billing can see. There's things that are kept mysteriously away from billing. Billing can see dispatch protocols. Billing should know that certain levels of condition or symptoms can be dispatched at the ALS level. Dispatch protocols are, each service has a list of what would be at the ALS or BLS level. And if this is not decided at a county level or at the city level, it can be decided at the service level. Your medical director makes that call. And what the medical director says, look, chest pain is always ALS. Abdominal pain with certain symptoms might be ALS, but straight abdominal pain is a BLS dispatch. If you know what that list is in the billing department and your crews document how they were dispatched, then you'll have a better clue if they were sent out ALS in the first place. And then you take their documentation along with how they were dispatched, and there's information in their documentation that you need for billing. And I was asking you earlier, do you find things in the narrative? It is not just the narrative that drives the train in billing. It is the whole trip report. And what I tell field providers is narratives are not the most important thing, and that they do not need to write the great American novel, because a lot of people are not good with grammar. They need to write essential information. And a narrative is a critical component of a trip report, but it is not the only thing. And particularly as you're barreling toward ICD-10 in less than 60 days, you need to understand the history of present incident. And that is not usually in your narrative. That is usually someplace else in the trip report. So you want to look at all of these things. You want to be looking operationally. So if you know how the call was received or dispatched and what level they were dispatched at, you may find that you have a legitimate ALS-1 emergency call. You need points of pickup, because the point of pickup drives the zip code that has to be on every claim. Where your origin and your destination is has to be on every claim. You are paid based on where the trip started. Your patient condition on arrival and during treatment and transport phases. Things like, are your crews documenting how the patient got from the bed to the stretcher? Sometimes there's this miracle of modern EMS. A lot of miracles happen in EMS where they miraculously got from the bed to the stretcher. No, it would be helpful to know if it was a stand, pivot, and assist. It would be helpful to know if it was a two-man sheet lift. It would be helpful to know if it was more than a two-man sheet lift. Maybe you have morbidly obese patient. The four-man sheet lift will paint the picture for you. It also helps support medical necessity. And when you're looking at the trip report, those are the kind of things you want to look at, because they help you know where to go. And folks, when I say signatures are an issue, I cannot tell you in the past 6 months alone how many calls I have gotten from providers who were up the creek without a paddle because of signature issues. That claim If it is not signed by your crew and it comes to you for billing, you have an option. Do you know what your option is? You can send it back to the crew to get a signature. Do you have an addendum policy? Do any of you have a policy for an addendum to a trip report? Okay. I think I addressed this further on, but I'm going to speak about it right now, and then I'll touch on it again. In the information and the guidance and the regulations that we have from CMS, the Center for Medicare and Medicaid Services, there's information that we follow, the ambulance manuals, but there's information that impacts all healthcare providers. So this particular issue on addendums is not in the ambulance manuals. It's in a physician manual. And what it says is that you can have an addendum to medical documentation for something that was materially missed at the time of documentation. You can send a trip report back. And what you want is, it is a new entry. Nothing ever gets X'd out of the original entry. This is new entry under the original entry. It gets signed and it gets dated. And if you send a trip report back because either you do not have a signature or maybe medical necessity is not clear, like it's almost there, almost, but not quite, and almost only works in hand grenades. You do not have to get right on top of that person to blow it up. You just have to get close enough. That's the only place it works. You need to have clear documentation of medical necessity. And so if something is missing, you can send it back to the crew for an addendum. But here's where having a policy in place will protect you. The policy says it has to be a new entry. The policy says it has to be signed and dated. And the policy says it has to be turned around quickly, like maybe by the end of their next shift. Because, and I did this with you this morning and I did this with you yesterday, if I ask you what you had 3 weeks ago on a Tuesday for breakfast, none of you can tell me unless you eat Cheerios every single day of your life. So if I'm going back to a crew member who is transported heaven knows how many patients, and I give them so long to return a trip report to me, how accurate is that information? And do you want that crew member standing to testify several years later? Oh yeah, they sent trip reports to us back all the time. Billing department wanted us to make it so they could bill it. And then that's the other piece. If you're going to have a policy, you make sure that everybody understands that you are seeking additional information, not bill-driven information, additional information. And sometimes you cannot make a silk purse out of a sow's ear. In other words, you may not be able to seek additional information because it just does not exist. Maybe medical necessity was not met. Maybe it just was an ambulance trip because it was an ambulance trip. And that's fine, because that bill isn't going to Medicare or to Medicaid. That's just fine and dandy. So you can get trip reports corrected and fixed, but have a policy. And nobody is to ever fix a trip report just to make it billable. Make sense? Is everybody good with that one? That's an important one. Okay. Now, we talked earlier about Medicare's payment policy. And what you want to make sure you are seeing is it clear to you that the patient's condition meant they couldn't go any other way? Because that's what the national payment policy from CMS says. Medicare covers ambulance services if they were furnished to a patient whose condition at the time of transport, not when they went to the hospital, at the time of transport, is such that transport by other means would endanger their health. And payment for ambulance depends on the patient's condition at the actual time of transport, regardless of patient diagnosis. Now, I told you earlier that we audit. We audit all kinds of services. And we take a random sample of claims, and we look at the trip report, and we look at how the billing was done, and we look to see if it matches, first of all, that they billed what was actually documented, and compliance was met, there's no underpayments, there's no overpayments. One of the things that we see happening over and over and over again is that the trip report might say the patient had a past medical history of COPD or a past medical history of congestive heart failure. And then it'll say something like, arrived, found patient in room 304, transferred patient to cot, patient care transferred to facility, patient transported without incident. In other words, you got bupkis, nothing. Nothing at all. So what you do, because you're billers, is you'll look at the past medical history, you'll put down CHF. No, no, no. That's not why the patient's in an ambulance today. And what's more, that's a diagnosis. So hopefully your crews will be getting documentation training and understanding that you need more from them, or that might be a trip report that goes back for an addendum. And by the way, you get a crew member or two who gets enough trip reports coming back to them for addendum, it can improve things. Or if management learns that enough of these trip reports just aren't cutting the mustard, it can improve things. But from your perspective, you need the patient's condition at the actual time of transport. And to be deemed medically necessary, Medicare says the patient must require both the transport and the level of service provided. Because what Medicare says is medical necessity is met if the patient's condition requires the vehicle itself or the specialized services of the trained ambulance personnel. Now, you saw me make a big fuss and do a song and a dance about this when I'm talking about it from the documentation perspective, because that really is the crux of the matter. When you're looking at a trip report, you already know the patient needs to go someplace. That's why you were called. The question is, did they need to go in an ambulance? And what makes the ambulance, what is it about the ambulance? It's got four wheels and, a steering wheel, and it goes. What is it that's so specific about the ambulance? It's the people who are in the ambulance. It's the personnel. So is it clear to you that that patient needed to have somebody at their side? And I've had various questions come to me since I've talked about this. And questions are like, well, what if the patient's seated in a wheelchair when we find him? Or he's seated in a chair at a nursing home? Just because you can sit in a chair at a nursing home, I've told many of you about my son. My son is end-stage renal disease. He's on a kidney transplant list, but recently he got Legionnaire's disease. He was in an ICU for over 5 weeks, super ultra sick, and thank above and incredible nursing care, that young man is still here, and he's had to go for acute rehab because after 5 weeks flat and paralyzed and on a ventilator, there's no way he can walk or move or anything. He has to relearn those things. But I'm glad he's here to relearn them. However, he could sit in a chair. So if you walked in the room, and all end-stage renal disease patients end up on Medicare, if you walked in the room, you would see this 30-year-old young man sitting in a chair. And you'd look to yourself and you'd say, well, what's he need an ambulance for? Because he is so deconditioned, he would fall right off that. If you didn't have somebody there and he wasn't strapped in and safely restrained, he would fall right off. He has no muscle tone as a result of this illness. See? Do you understand? You can sit up. Well, you have the elderly who can sit, and nursing homes' jobs is to get them up and have them sit. So they can sit, but they might be Alzheimer's and a flight risk. Myra is my sister's mother-in-law. Sweet soul, really sweet soul. She was a high school English teacher, and she sang in the church choir, and she played organ. Lovely, lovely lady. But what eventually happened is Myra got Alzheimer's. And one day, my sister and brother-in-law found Myra on the floor of the kitchen. And they thought they'd lost her. They thought she had a heart attack or a stroke, or no, she'd found the scotch. And another day, they can't find her. She had stripped naked and she's wandering down the highway. Myra's, as her Alzheimer's progressed, Myra did not care for clothing anymore. So if Myra was in the back of an ambulance, she would also try and get loose and escape. So if she was in a wheelchair van unattended, not only would she strip naked, she would try and get out. Now she would be a danger not only to herself, but to every other driver on the road, as this 82-year-old lady's wandering around naked down the highway. Myra can sit nicely in a nursing home. Myra could not sit unattended in the back of an ambulance, of a wheelchair van. She is a flight risk. She is a danger to herself or others. So keep that in mind. It is why the patient needs to have someone at their side. And when you're in billing, there's words that scare you. Words that scare you are ambulate and sit. Those are two words that make you think medical necessity is not met. Look at the big picture of what's going on. Those are not bad words. There is a difference, too, between ambulating, and I already did my margarita routine. So this is ambulating. I can ambulate. No margaritas, I can ambulate. Here's what happens when a provider shows up to get a patient. They get the patient, and here's the bed, and here's the stretcher. Not very much space between those two. And you'll have one provider here under this arm, one provider here supporting the patient, and then the patient does the shuffle. The shuffle is a lot different than this. But what you'll see in your trip report documentation, because field providers are frightened of compliance too, is the word patient ambulated to the stretcher. Yeah, that took almost 20 minutes to ambulate to that stretcher 24 inches away. Again, look at the big picture of what's going on. And look at not only medical necessities we've talked about, but is it reasonable for the patient to be leaving a skilled nursing home? Is it necessary? And are they going to a covered destination? Do you have doc in a box here? Freestanding emergency rooms? You have freestanding emergency rooms, very popular. Here's how you can get medical care these days. You can go to CVS and see a nurse practitioner in one of those minute clinics, or you can go to a building that calls itself an urgent clinic or an urgent care center. That is not a hospital. That is a doctor's office. It smells like it's an emergency room, but it really doesn't pass the smell test. It is a doctor's office, and that is not a covered destination. And this is one of the dumb aspects of things. I'll be right there. Because it sure seems like Medicare should cover this. It should be an economical use of services. But it is not a covered destination. They haven't caught up. Well, two things. Here's the good news. Number one, if it's a pediatric place, it is likely not a Medicare issue. Okay, so the closest appropriate facility is a Medicare issue mostly. I'll come back to that, mostly. And if this is a Medicare recipient, then the closest appropriate facility is a Medicare issue. The Medicaid often has a similar requirement. In Indiana, you can't take a Medicaid patient across state lines and have Medicaid cover it. Even if the closest, if you're like on the border of the state, isn't that a pain? Because sometimes the nearest hospital might be, and we're talking about a line is like painted in the highway, that's it. So I'm on this side of the street or I'm on that side of the street. This side's Indiana, that side's Kentucky. Yes, Kentucky. I had to think about my geography there for a minute. Yes, Kentucky. So even if it is a doctor's office within a hospital, and many, many, many doctor's offices are within a hospital, it is a doctor's office. It's the medical office building. It is not the hospital itself. And as such, it is a non-covered service. Just because it's non-covered doesn't mean you won't get paid for it. Sometimes it is a hospital's responsibility to pay. Sometimes it's a SNF responsibility to pay. Sometimes it's a patient responsibility to pay. But you might find that this is a challenge, particularly with these freestanding ERs and people wanting to go to the freestanding ERs. Now, I told you about the trip report addendums, and you do have this section. I was right, it was there. You do have this section in your handout that shows you exactly where it is in black and white. You can read about the addendums from the manual. And if you have to go here to get any additional information, here is a policy approach that you can take. Make sure that your people know it's not bill driven and that your addendum should be the exception, not the rule.